half a year, but mostly people come to places, to dentists to pay. And you must understand the reason of pain. Not always caused by damage of tooth. It's possible to provoke pain due to a problem with the temporomandibular joint, muscular spasms, asymmetry of muscles, and a lot of another reasons. Not just teeth damage. And opposite tooth or teeth damage can provoke pain, not just in location of this teeth. And usually in orofacial area, pain is radiated. You must understand the principle of pain. Pain sensation. What is a pain mostly? Sensation or psychological condition?
Sensation.
Due to in accordance with definition.
With preneuronic receptor, pain sensation.
In accordance with international approach, pain is sensation. But sensation is the result of sensory processes. But pain includes a lot of emotional responses. So mostly pain is conditioned. Pain is conditioned, including sensation, emotional response, autonomic responses, defensive behavior, motivation, defensive behavior, excitation of brain, total excitation of brain, because pathway, nociceptive pathway are plural and projected to a lot of brain areas, hypothalamus, amygdala, and other parts of the nervous system, a lot of brain cortex areas, some of the sensory primary, some of the sensory secondary, prefrontal cortex includes orbitofrontal cortex, singular gyrus. Very important part of the limbic system, but responsible for emotional processing. So emotion includes always negative emotion. Pain includes a lot of negative emotions. Conclusion: pain is condition. Pain condition. Condition. It consists of 5 components. First, sensation. Sensation. Next, simple defense reflex like withdrawal. Withdrawal, for example, needle or fire and pain response. Withdrawal reflex is lower nervous activity, maybe it's more enough spinal cord or lower part of central nervous system. Withdrawal reflex. Withdrawal. Next. Component of pain.
Yes, withdrawal.
Withdrawal is an escape. Next, brain excitation. Next, emotions. Negative emotions. Emotions elicit autonomic response, like stress response. What response, prevailing response in oral cavity during your dentist stimulation, dentist procedures? What is autonomic response in oral cavity, for example, during your treatment?
Like close the mouth.
No, if you put
Swelling.
Producing saliva.
Salivation. For example, salivation is defensive response. Maybe somebody want to talk instead of me? Please, continue, next. Next. Yeah, I can take the red one, and you will have well, no problem. Absolutely. You don't listen to motivation to escape pain because it's negative. And motivation, defense behavior. Defense behavior. It's very important to understand what is a defense behavior. Two types, active avoidance and passive avoidance. Avoidance means escape, delete. Active avoidance and passive avoidance. Active and passive avoidance. Again, example with the patient with pain located inside house, single tooth. What does human do when he feels senses pain?
Sometimes we use some tablets, or sometimes we continue with pain, and we have to remove pain.
How? Okay, drugs,
The body-
medication.
We use drugs.
What is possible to do? If you have pain, what is
Relax. Like relax.
Professor, tablets.
Relax is pain.
No.
Like his
No, like a headache. Sometimes like headache.
No, chemical compounds. Morphine, like morphine, chemical compounds.
خب گفتم دارو drugs.
Of course, medication. What next?
Use some tablets.
Go to doctor.
Doctor, sure.
It's active avoidance.
Professor, but
Drugs, treatment, drugs. No, not drugs medication. Drugs is to double meaning. Drugs, alcohol.
Professor, Iranian people just
Medication.
have gelatin.
Take alcohol is
Well, language.
it's anxiolytic. Medication, doctor, and
Treatment.
other activities to distract. To do something to distract your conscious, your mind from pain. Distraction. And aggression. Because your patient may be angry
Yes.
due to this prevalence of this response. Not because he is bad person or bad educated. It's an active avoidance. What is passive avoidance? When a person doesn't have time to do this, but pain bothers you, bothers the patient, what does he do when he is chewing, eating food?
I use another tool except that tool.
Don't
Decrease
use
the
this
pain.
decrease tension, decrease function of organ. Decrease function of painful part. Painful part. Decrease function. It's passive avoidance. Decrease activity. It's passive avoidance.
Maybe a sleeping.
If it's possible, this decrease activity, active avoidance, increase activity to treat or to distract, to work more. And we had experiment with weak painful stimulation, electrical stimulation of hand, arms, or cheek, and the student performed cognitive work like special test, and some students performed better with pain because pain stimulated brain. Some students performed worse compared with normal condition.
Oh.
Sometimes pain stimulates brain, and when you want to distract, you can perform your activity better. But actually, pain is negative emotions, making dominant center. Dominant center will hurt you, bothers you every time because dominant center increase excitability of brain and distract you from your work and others needs. Pain create pain gives information about the vital need.
Pain.
Vital need, tissue integrity, tissue normal functions of tissue. This pain controls normal function. Normal function. Pain is information. Pain information about damage or possible damage, dangerous, harmful situation, threat, damage, threat, control mechanism pain. So pain is response to damage or harmful stimulation. Depends on intensity. Harmful stimulus. Pain sensitivity in different people, in different time of day, in different conditions may be different. How to assess pain sensitivity and for what? At first, to understand amount of anesthetic. A lot of anesthetic is harmful for nervous tissue and nervous fiber can be done from a lot of anesthetic, but especially in people with diabetes. So it's better to understand effective dose of anesthetic and decrease it as possible. So you must define pain threshold, especially if your patient has allergy to anesthetic. What can you do? With a deeper caries, for example, inflammation of part. It's necessary to assess pain threshold. What is a pain threshold? Now, who will be my patient? Yes, we will compare. Close eye. I will increase intensity of stimulus, and you will see moment when you will feel pain.
Pain.
Yes. How did you discriminate non-painful and painful stimulation? What happens in your brain? How do you understand?
I feel
This is
pain.
What is a pain? Before the same stimulus.
Yes.
What happens when you feel pain?
I feel some pressure in my
Pressure, but pressure is not painful at first. Then
and deeper pressure
and
cause the pain.
what is a pain?
Action potential.
Sensation,
In your mind. How you can estimate this
That's
is pain?
dangerous
Different
for
situation.
You understand, but
In the hypothalamus.
غمض.
do you have pain?
No.
فشار بدأت.
Yes. What is the difference between non-painful and painful in your mind?
It's a different threshold. That's when you put slow, it's not dangerous, and I think it's not matter for this
How do
one.
you understand this? This is dangerous.
When pressure more, I think that's be dangerous because cut my finger or
It's
something
your,
like that.
in your kind of cognitive. but the pain may be unconscious and cognitive with emotions. What is emotions? Emotion. Negative emotion.
Negative,
It's negative
negative
emotion.
emotion.
When you feel negative emotions, it marks pain. То есть pain threshold, значит, pain threshold is the minimal amount of harmful, dangerous stimulation when you feel the first negative emotion, discomfort. Нарахат. First contention. And different person has different pain threshold. So very important. Score for pain sensitivity, pain threshold. Остальные, да.
Hastanede.
Hastanede.
Pain threshold. How to measure pain threshold? You must have device with applying stimulus of a given intensity. For example, electrical current. How to measure? With electrical current, electrical stimulator, with temperature, to heat or to cool, heater or cooler, and increase temperature until the moment of pain. Or mechanical pressure with dose. Mechanical pressure. I don't have here a scale, it's a simple device, but usually it has scale. To understand how much stimulus intensity we apply to provoke pain.
And this will be different, right? The threshold for each person will be different.
Yes, of course. And, pain threshold is determined by two systems: nociceptive system, nociceptive pain system, nociceptive sensory system, or pain system. Pain for human. For animal, we can't use term pain because we don't know what an animal feels. Animal can't be described. Nociceptive and second opposite system. Antinociceptive. Antinociceptive system. Adaptation to pain, decreased pain sensitivity happens mostly in the central nervous system due to descending pathways from upper level of antinociceptive system, cortex, hypothalamus, amygdala, and brainstem to gate nociceptive neurons. A simple scheme. This is a scheme of nociceptor. Afferent pathway. I will show on the body. It's a simple in oral facial area the same. Then gate. Most of drug pathways are include spinal thalamic, spinal mesencephalic, spinal reticular, includes neural spinal cord. First neuron, it's like gate by chair. And then this neuron relays signal to upper part of brain. And brain controls this pathway.
Endorphin release milk produced in the hypothalamus and
Yes.
hypophyse
You are-
and release.
yes, very well, you are right. And the antinociceptive neuron is inhibitory neuron. It's simple scheme, antinociceptive. ANCS, I might so.
It,
Nociceptive neuron inhibits this with presynaptic inhibition and postsynaptic inhibition. Previous colloquial, presynaptic inhibition, postsynaptic inhibition is possible. It's principle. This neuron may be located in brainstem. Upper level can control this.
somatic.
This principle. This is antinociceptive system. This is common principle. At least you must understand the common principle. Secondly, details are not so important. Common principle. No.
So we should write this for pain or
It's
Okay,
a
like-
nociceptor.
This is a pluric.
It's nociceptor. It's a pain receptor.
yes, I know. We should write in our table.
No. Now no.
Put that
Only now I'm explaining about pain threshold. And the balance between ascending information from receptors, nociceptor, non-nociceptors, and descending pathway antinociceptive system defines pain threshold. Activity of antinociceptive system is changing during day and night. After sleeping, the rest, antinociceptive system becomes more active with tonic activity, continuous activity permanent, and pain threshold is minimal, lowest in the morning. If you want to erupt tooth, it's better to do it during morning.
Mhm.
This pain threshold increase in the morning. Consequently, pain sensitivity decreases. Increase in the morning. Increase in response to emotions, positive emotions. Positive emotions. Every positive emotions decrease pain sensitivity. Increase pain threshold. Positive emotions and aggression. Aggression increase pain threshold, decrease pain sensitivity. Because during fighting, war, fighting with enemy, you must concentrate on your actions to win an enemy. So you must not distract and don't pay attention to pain. Don't pay attention to aggression. Opposite situation, decrease pain threshold. In the evening, before sleep, negative emotion like fear, aesthetic emotion, fear, sadness. So if your patient has fear, is afraid, да я побежала делать. Значит, so your patient has fear, it requires more anesthetic. For example, when I have a dentist procedure, not deep caries, I don't wait for it. I don't use anesthetic because I can control my pain threshold. I relax,
How?
think about positive emotions.
That's work.
Yes, you can adjust your mood, your patient, but your patient must understand that it's possible. If your patient has fear, so more anesthetic. What do you think about gender influence? Gender influence actually depends on between women reproductive age and adult and men, depends on day of woman cycle. But average, in average, who is more sensitive, man or to pain, more sensitive, men or women?
Woman.
No,
Yes.
men,
Men.
men more sensitive.
Yes.
We are more strong. Stronger. Because a woman must control your pain, pressure during delivery. Um, and women are more brave, usually. Yes. So possible that men will have more fear. Well, depends on personality, of course. So you can influence on your patient with your word, explain. Why, for example, I prefer to skip anesthetic? Because a little sensitivity is good to give feedback to doctor what happens, and maintain normal functions of my nerves. Faster recovery after treatment. Less edema. It's good. Of course, with deep inflammation from valve, that's impossible, or tooth eruption. But
For tooth eruption without.
No, that's impossible.
It's impossible. Why brain has proper antinociceptive system, and this system has tonic activity always. This activity can become more during pain stimulation, but it exists exists even without pain stimulation before. Background. This antinociceptive system has background tonic activity. For what? Pain is important to control function and signal, pain is signal about damage or danger. For what brain decreases pain sensitivity all time, even in the absence of painful stimulus. For what? It's necessary to decrease pain sensitivity.
Because of prevent damaging to the nervous system.
Yes,
Actually, you are right.
there will be access for
Prevent
signals.
prevent excess because you don't know who, maybe your body meets very strong painful stimulus suddenly. Suddenly, it's necessary to be prepared. Excess of pain provokes pain shock condition. Shock is transmarginal inhibition, and you blocks your behavior, defensive behavior. It can damage your brain, nervous system, to kill some neurons. This is bad.
Diabetic, such as diabetic people.
Yes, in people with diabetes, nervous system is changed. Change sensitivity depends on the stage of diabetes.
So this shock is like when a person know that, for example, his family like did in war or something. So there are some people like have a shock, they will get crazy.
Shock may be provoked by excess of painful stimulation. It depends on personality, person, type of stimulus, condition, functional condition, exhausted person. It's more possible. And condition nervous system, maybe some diseases like diabetes, damage of nervous system, because diabetes it's a systemic disease with a decrease of functions due to lack of nutrition. It decreases dynamic of glucose taken from blood. It decreases function at first nervous system, and decreases the velocity of action potential propagation. So all your center works slower, slower responses. And the one problem in diabetes, so that's good example I recall now. Diabetic person with many years of diabetes sometimes does not feel pain, does not sense pain with weak stimulus, in response to weak stimulus. This person can damage food. Rock, damaged food, and he don't see it, doesn't see it from the here now back and forth, and don't pay. He doesn't pay attention, but he doesn't feel pain. But inflammation here, immunity system is less active, immunity disturbance sometimes in diabetic person. And this inflammation can provoke propagation of bacterial infection into blood and then amputation.
Yes.
Because
Again,
It's fragment, it's fragment. So it's necessary to control by visual system and study bodies. Next problem, disturbance of balance between excitatory and inhibitory mechanism processes in the brain. Because inhibitory processes are more sensitive, inhibitory synapses are more sensitive. What happens after tooth eruption in diabetes? Phantom pain. Do you know about phantom pain? After tooth eruption, after recovery, this person can feel presence of this tooth and pain.
yes.
Phantom pain. Why? For what is maybe phantom? Because in the central nervous system, in sensory pathway, nociceptive pathway, some neurons became more sensitive and usual tactile information, because in the, this side after tooth eruption, of course, this side has both neural aiding, usual neural aiding, tactile neural aiding, and they have activity. This is weak activity, low activity. It's not painful, but nerve centers are more excitable, more sensitive, and non-painful stimulation provokes activity of painful centers without pain, and painful centers send signal to cortex, and cortex recognize it like pain. It's a mistake of cortex, but cortex doesn't understand what happens in peripheral nervous system. Cortex receives signal from limbic system,
Thalamus.
from hypothalamus, thalamus, and recognize it like pain. Therefore, we must understand sensory.
Excuse me. Why in the length of the night more pain is than the length of the
At the night, at the night. In the morning, usually decrease pain. At the night, because decreased functional condition of the brain, tired synapses, and simple explanation, tired our antinociceptive system.
and some
I think ICP intracranial pressure in the night increase, but
Do you mean vascular circulation, blood circulation in the brain?
in the night increase.
Maybe I don't know about it. Maybe it exists in
Vitamin-
additional factor, but mostly it depends on pain pressure. Is defined by balance between nociceptive and antinociceptive system. The change of blood circulation and brain blood circulation, of course, can influence indirectly on activity of central nervous system neurons. This balance depends on antinociceptive system. Antinociceptive system can be tired, and production of endorphins. During sleep, our brain produces more endorphins,
Endorphin.
and in the morning, enough concentration of endorphins. Of course, especially if you see good sleep, drinks. Well, maybe details.
In the night, decrease endorphin produce.
Increases. In the night, your brain produces endorphin. Endorphin helps to sleep. How to sleep. Okay. In the night. Endorphin can affect not just inside synapse, because endorphin is peptide substance. It works like peptide hormone, and endorphin, beta endorphin, produced by neurons. Endorphin. Beta endorphin lives in the blood period of half time life period, about half hour inside.
نيمة عمر half نيمة عمر
Half of hour.
نيمة عمر it's نيمة عمر papirsiz giysik نيمة عمر نيمة عمر ضرب نيمة عمر
Half life.
Because of our sound.
half life
Half life.
نيمة عمر
I need
For
to
example-
see. I need to
for
see
ex-
right.
For example, ketrolak ampul half life in the
Nime or
omra.
I can write for you.
I must see
Nime.
right.
Professor, I write it for you.
أين ما نمشي بزرگ
هبل والله هبل.
Me.
عمري أنا أعرف إزاي.
Nime omr.
Well,
Such as ampul ketrolak ampul half life in the blood 80 hours. 80.
18
hours.
Also not
Less than 1 day. But endorphin is endogenic substance. It can produce it all the time. It's a good that endorphin can be used not just inside synapses, but it can go to into blood, and affect across blood on all the brain. Well, details about sensory nociceptive sensory system, brain system. Like the usual regular sensory system, nociceptive system has peripheral division, receptors, pathways, and cortex division, central division. Brain system has a lot of receptors, nociceptors, and non-nociceptors. Special nociceptors. Nociceptors, there are several principal classification, model classification. Nociceptors, or HTMR. What does it mean, HT?
Homeostasis.
High threshold mechanoreceptors. Free nerve ending.
Free nerve ending.
Free nerve ending. This is very important. Special nociceptor are free nerve ending, like this. Afferent neuron, but whatever. Free nerve ending. Afferent fiber, maybe two types, principal two types. It's important for you. Delta with speed 5-15 meters per second, thin myelinated A delta, or C, second type, C.
Unmyelinated.
Unmyelinated, slow. here moderate speed 550 meters per second. C,
1, 2.
better.
It will be between 1 and
Speed of action potential.
yes. C, it will be between 1 and 2. Or
1 meter per second. 0.13.
Yes, we had it in discovery.
we studied in physiology also.
Well, but 1.3 or 0.5?
1 to 1.
1, 2. 1, 2, 1, 2. In different investigation can, I think that was right. Very well, recall the explanation. It's useful. A delta and C. A delta always have mechano sensitivity mechano receptors. C, polymodal receptors. Polymodal receptors. At first, chemoreceptors. They also are sensitive to heat or cooling temperature, excess of temperature, pain temperature, and maybe to third, sensitive to mechano stimulus also. Some details. And in response to inflammation, most of polymodal receptors becomes mechanosensitive. It provokes peripheral sensitization. I will explain it later. What must you remember? Two principal groups, A delta and C. A delta mechano, C polymodal with chemosensitivity. Chemosensitivity, just C. A delta doesn't have chemosensitivity. Chemosensitivity to substance releasing in response to damage. This substance called algogens. Example of algogens. Hydrogen ion acidosis, example lactate. Histamine, mast cell, histamine. Potassium prevails inside cells. Breaking of plasmatic membrane, of course, the concentration of potassium becomes more with damage of cells. Histamine, what more? Prostaglandin. So non-steroid anti-inflammatory drugs blocks phospholipase A2, responsible, it's enzyme responsible to prostaglandin synthesis. This is principle of this drugs medication.
Decrease of the pain.
Decrease pain, inflammation, pain both. We've got prostaglandin, and for example, substance P. Recall experiment with dermography. Do you remember?
Yes.
And now it may be useful for us. A receptor, because here you stimulate receptor, mechano receptor, tactile receptor, and pain receptor, both. Receptor formed by several branch of one single neuron, afferent neuron. You stimulate here, information is propagated, not just to central nervous system, but with axon reflex. It's very important for pain, axon reflex. Along of another branch of axon, and it provokes a release from afferent enzyme, substance P, and another, I will not say name because it's not so much. Substance P, delay blood vessel, you have hyperthermia. red lines, and substance B influence on receptors, on nociceptors, chemonociceptors. C fibers.
Vasodilation of the vasodilation.
Vasodilation. Right.
Mhm.
My group performs this.
Yes, we do.
Your group. So what? Okay. My condition for this one. The same happens in response to any damage. We have axon reflex and release of substance B in peripheral tissue, in interstitial fluid. It provokes hyperemia and increased pain sensitivity here. It's called peripheral sensitization. Peripheral sensitization. Peripheral sensitization. Sensitization. Because this tissue will be more sensitive to painful stimulation. Becomes more sensitive. Peripheral sensitization is one of the mechanisms, not single mechanism, but one of the mechanisms. Peripheral sensitization. Pain may be classified to several classifications. For example, properties, features of pain sensation. First pain or second pain, or two types of pain. First pain or second pain. Do you feel pain?
Yes.
Super. Can you understand what exactly what part of
Secondary pain.
What
Secondary
does
pain.
the part of your finger has painful stimulation? Do you understand? Good job. Good job. Yes. And you feel sense that firstly strong pain depends on my pressure, more strong, less strong, and the exact place. What happens now with your sensation? Now, do you feel something?
And I just especially
Yes. And what is about place? Place becomes narrow, less, or küçükler,
Pozoklar.
pozoklar.
damno işe bir yakın.
Kuchikta.
Küçükler.
Yes.
Because pain decreases. First sensation was first pain, and then this person has second pain. First pain is stronger. His intensity is proportional intensity of stimulus, more pain. Brain defines exactly location where, adjust. And second pain is unstable sensation, more or less. It may be less place or more place, depends on stimulus. If you have inflammation, it becomes more, and second pain may be longer. With first pain first, epicritic, good, well defined, well discriminated. And the second, worse discriminated and stable. First pain is primary, and then you can have second pain. First pain is caused by A delta receptors, second C receptors, mostly so. First pain A delta, second C receptors. Can person feel pain after full treatment, when this person already doesn't have problem in organ? Can this person feel pain after treatment, full treatment?
Directly after the treatment.
After treatment, you have problem in skin, in muscle, you have pain. Then you recover in this situation, and your muscle becomes normal. Can you have pain after
Yes.
it?
Yes.
Yes.
Chronic pain. Why? Because central nervous system changes sensitivity again in pathways, in sensory pathways. So it's called central sensitization. Long pain, long-lasting pain can change sensitivity of pain centers, and after treatment, after reparation, recovery, anyway, this person can perceive tactile, usual tactile stimulus, like painful stimulus. Next question. For example, you touch your hand with very weak intensity, like cards. If you do it during 20 minutes. 20 minutes, it's mirror. Can you feel pain after 20 minutes?
Yes.
Yes. Yes. It's not painful.
May have
Pleasure.
increased the
Make a pleasure.
Yes.
Mesela
But with summation of signal,
Geçen bir şey yapmazsa da
summation signal nerve center and brain recognize it like painful stimulation. The brain has sometimes a lot of mistakes with those things. Next, illusion. Illusion. It's very interesting. If you take three glasses with water. Glasses with water. You can do this experiment at home. Значит, water first and filled with warm water, warmer than your body, not hot, warm, only warm. 30 degrees. And between them, glass with water cooler than your body, but not so cool. And then second, as warm and cool. And put three finger, central finger, cool water, and another cider finger in warm water. And each finger doesn't have pain, but in this situation together, you can feel pain.
Why?
Why?
Integration of brain, mistake of brain. It's illusion.
receptor
Because the brain receives signals like.
It's integration of signal in tablets.
Ah.
It's illusion. Illusion. It's illusion. One finger doesn't have pain because it's not painful stimulation. Maybe even pleasure. But together, three finger. Try it at home.
Don't. İvan ne dedi?
It's an illusion at home.
At home.
At home.
Açtı.
As Hane. Well, значит, pathways. I will draw a scheme of pathways. First, I will draw a scheme, nociceptive, painful pathways from the body. But for you, it's more important to know exactly oral function. Information from tactile receptor is propagated with lemniscus pathway. Lemniscus pathway. Non-nociceptor. Non-nociceptors, tactiles. Nociceptors, touch. But I give an example with long-lasting touch, anyway, you feel pain. So it has participants in pain estimation and pain control. Lemniscus pathway does interlay in spinal cord, then amygdala, and the
Cortex.
thalamus. Thalamus, yeah?
Thalamus and this
somatosensory.
Cortex.
Somatosensory and VPH nucleus. Thalamus. Thalamus. Third neuron, да? The classic scheme of puzzle. First neuron, afferent, second brainstem here, and third and thalamus. And then cortex. Somatosensory primary,
şansı çeşidi, Emperos çeşidi.
somatosensory secondary.
Ayaktaki kişi.
Bu soğanı var mı?
Lemniscus pathway.
Lemniscus pathway.
Yeah, lemniscus pathway.
It's like this, correct?
Yes, well, yes. Lemniscus pathway has a well-discriminated somatosensory map. Discriminate topographic map. So your brain understands what part of your body is stimulated. The two map. Map.
Şansı çeşidi.
Then, another system, it's called anterolateral system, but the name is not so important. Spinal thalamic. Spinal thalamic, you know this tract also. Spinal thalamic relays
الميدولا
relays in spinal cord. Gate. Here.
Yes.
And then crosses spinal cord and goes up to thalamus, adjacent side. Again, VPA, thalamus, VPA, specific nucleus, and non-specific nucleus. Non-specific nuclei. VPA is specific somatic nucleus. And spinal thalamic doesn't have good discriminative information, doesn't convey discriminative information. It doesn't have good somatotropic projections, and can't convey information, exact information about location. Location is worse, but it exists. VPA again, somatosensory. And non-specific in associative area, right? Includes orbitofrontal cortex, another part, prefrontal cortex.
It's lemniscus pathway.
Lemniscus white.
Aha,
See?
right.
See? Here red spinal thalamic. And spinal reticular. Easy. Afferent neuron, again, spinal cord, and spina reticular. Where will be the third neuron? Spina reticular. Reticular.
in the thalamus.
No, before thalamus.
Medulla.
Reticular. Reticular formation. Motor control.
This one is
Reticular.
Brainstem.
Brainstem, yes. Reticular formation. Reticular formation. Значит, sensory system lecture. Specific pathway, non-specific pathway. Specific pathway has 3 neurons, primary 3 neurons. 1, 2, 3, 2 thalamus. Non-specific pathway has a lot of synapses. Non-specific pathway are passed across reticular formation. And from reticular formation to non-specific. Propagation, excitation in non-specific areas associated with. And the last pathway, spinomesencephalic, again, dorsal horn, spinal mesencephalic. What is the mesencephalon? Midbrain. A more important part of midbrain here is periaqueductal gray matter. Do you know this?
What?
We not just great.
A gray matter.
Periaqueductal gray matter. Part. Do you know it?
No.
Значит, here and branch to reticular formation and brainstem, and from periaqueductal gray matter to limbic system. It's limbic system.
Limbic.
Limbic
Limbic.
system, hypothalamus, amygdala.
Attached together.
Yeah.
Limbic
And
system.
this projection to reticular formation to limbic system activates antinociceptive system immediately.
Limbic
Activates antinociceptive system. Nociceptive and antinociceptive system are interconnected, and the brain center has common brain centers. Reticular formation, bug, and parts of cortex, frontal, somatosensory cortex, muscular system. About oral fascia, oral facial area. Oral facial area. Pathways from oral facial
So we
area.
should draw this in our table?
Yes, yes.
Alright, okay.
In your table must be about pain nociceptors, A delta and C. That's
We
very
draw it.
Huh? Yes, yes, let's see. Значит, yes, and quality, A delta, да, A delta mecano, C polymodal. A delta
We should
mecano,
withdraw?
C in the table. My group field tables about sensors. Polymodal. I wrote here.
Yes.
Polymodal. Polymodal and mark here chemo, mechano, temperature. Chemo, mechano, temperature. Chemo, mechano, temperature. Polymodal. What is the type of receptor? Primary or secondary?
Secondary.
Primary.
Primary.
Just primary. Primary.
Yes.
Sense organ. Sense organ, all part of body. All part of body. Skin, mucous, muscle, heart, all parts of body.
Yes, because all parts of body can feel pain.
Muscles, muscle, blood vessels. What is the reason for here to have headache? Headache, pain in
Pressure.
headache, pain in head.
Yes.
High blood pressure.
Well,
Blood pressure.
where nociceptor in brain absent. Nociceptor exists in blood vessels.
Yes.
Just
Because
blood vessels.
in the treatment for brain, some persons stay like awake and they don't feel anything.
And brain doesn't have it.
Yes.
Doesn't have nociceptors. Headache is provoked by stimulation of nociceptor located in the wall of blood vessel. Blood vessel. But the brain doesn't have
Yes.
it. Doesn't have
Yes,
it.
that's correct.
And more superficial parts of body contains more A delta. Internal system more C receptors. It's rational. The skin contains both, but more A delta. Internal organ contains more C receptors. Polymorph. And A delta pathway prevails for lemniscus and spinothalamic. C from spinal mesencephalic spinal reticulum. So a C receptor provokes more second pain, I say. Picture about the pathways from orofacial area. Tooth. What is a nerve? Pain nerve.
Sensory.
Mandibular
What nerve? No.
nerve.
Afferent.
Free nerve and
Trigeminal.
Trigeminal.
Trigeminal.
Trigeminal nerve.
It has a free branch.
Mandibular range.
Mandibular.
Yes.
Range.
Visual. Rather
Axis,
supra.
Orbital.
Yes, supraorbital.
Schizophrenia range. Then, actually, we have three parts of trigeminal nuclei in brainstem in medulla, and pain is transduced through spinal nucleus. Spinal because near spinal cord, in lowest part of medulla. Spinal nucleus. Spinal nucleus.
Oralis and caudalis.
Actually, mostly caudalis.
Caudalis.
Pain with specific pain stimulation is propagated across caudalis, but it's difficult in science to separate exactly. Everything may be overlap. For me, it's difficult sometimes to find a good picture reflecting all modern science. Some mistakes may be on details. Spinal nucleus, it's enough. Spinal nucleus. It's responsible for pain and temperature sensation. This pathway is responsible for pain sensation. Where is the third neuron?
Third neuron in thalamus.
Thalamus, specific nucleus. BPN, specific nucleus. Thalamus.
All of the sensation go to the thalamus and before go to cortex.
What
Cortex.
areas of cortex receive signal from the brain?
Without olfactory nerve. Huh?
Somatosensory primary and secondary.
And secondary. Yes.
And branch of spinal ventral trigeminal tract, branch of ventral trigeminal
Motor nerve
tract
of the
goes to non-specific nuclei, like here. Non-specific thalamic nuclei. And then from here to limbic system, limbic cortex, limbic system, emotions, and prefrontal cortex. The first part is responsible for primary pain, first pain, sensation, location, where, intensity, time of duration of pain. Second pathway is responsible for emotions and motivation.
PFC.
PC, prefrontal cortex.
Prefrontal.
Prefrontal cortex.
PFC.
Prefrontal cortex.
This
Motor control.
yes, this is the area responsible for idea
Yes, for to control behavior.
behaviors. Yes.
Limbic system.
Upper control of behavior. It forms dominant center, dominant motivation, responsible for dominant motivation, makes decision about behavior.
Limbic system.
Limbic system.
Which, higher
non-specific local.
Yeah. And cortex. No? Cortex. Picture of cortex. Somatosensory primary cortex. Somatosensory
Sensory primary.
Area of
Sulcus of
face. That face area.
Yes.
Somatosensory secondary, approximately here. And prefrontal
Prefrontal.
cortex.
The frontal pulp.
prefrontal cortex. Especially special zone here, very important for pain, orbitofrontal cortex. For FC, orbital
Frontal cortex.
frontal. Orbitofrontal. Cortex. You have a picture in my presentation about singular gyrus and insula. Singular gyrus and insula. They are located. How to say? Insula integrate information. It's a part of living cortex. It integrates information from olfactory system, taste system, and brain system. And singular gyrus is an important part of the living system. But here I might only one. It's enough for you. Так, and autonomic last. Значит, do you feel table fully? And last part about anti-nociceptive system. Where it's located? No. Anti-nociceptive I explained. Until I explained the presentation. Another very important part for your profession. I'm going to explain quickly how brain can feel pain in another part of body outside of stimulation. Why it may be. I will go.
Yes, in oral cavity, like a lot of times, the patient in oral cavity, a lot of patients sometimes feel the pain in mandibular teeth, but it should be in maxillar. Yes, I see it in my father clinic a lot of times. Like the patient say I feel pain here, but actually it's here.
Yes, I will
Yes.
explain now why. At first you see that brain nerve trigeminal. Trigeminal nerve has a lot of branch. And one branch can innervate several parts. We can have a simple situation. I will explain this gate neuron. Gate neuron relays information, conveys information, brain defines language. Relays neuron receives signal from nociceptor. For example, from skin. So, more comfortable to explain. Because you have damage here, like pin, and you feel pain here. Okay, it's local pain. You locate pain in the same place, then you have stimulation. In stimulated place. It's simple. Another case. Damage of nerve. Nerve is damaged by muscular spasm or another reason, inflammation. But you have pain, you feel pain on peripheral part here, not where nerve. For example, you have spasm. It's better to explain in the body. You have spasm in what's on neck behind the back of neck, but you feel pain in your arm.
Substance P, just substance P
No,
releasing.
it's to do this innervation. With your muscle contracts and mechanically damage nerve has inflammation, nerve excited, and brain recognizes this stimulation as stimulation of peripheral part. Because brain doesn't understand what happens. And so you can feel pain in every branch, innervation by every branch of damaged nerve. Because your brain nerve damage upper, but you feel pain lower in the innervated part. It's radiating pain. Another case of radiating pain, very regular in the colorectal area. Afferent nerve has several branches. You have a damage here, but you feel pain here. It's a radiation. And the last case, possible case, I will explain another side. Gate, and this gate neuron receives signal from skin, and another organ together. Convergence. For example, from heart. You have damage in heart, but your brain located pain in skin. It's referent pain. Referent pain because brain recognize signal at first like signal from skin, from mucosa. Only then like signal from internal organ. If your patient has pain in left arm, left hand, left finger, maybe this patient has problem with heart. Because it's a referred by its own.
Such as when infarctus muscle pain in the epigastric.
Yes, it's referred pain. So when, for example, my friend said about some problem that it's possible to give a diagnosis quickly, I look at map of referred pain, what happens. It's possible in your profession also because referred pain is possible. Referred pain from muscle, and I remember I think this picture of referred pain from our facial area.
Visceral pain, yes? Visceral.
Visceral pain, but your brain recognizes like somatic pain. The brain has mistake. You have problem with organ, internal organ, but brain feels pain in skin, some part of skin. And last interesting case, the situation of convergence. Brain, spinal cord has antinociceptive neurons also, and gate neuron has convergence. May have convergence from thick A beta from tactile receptors and from A delta receptors
Thin.
and C receptors. A delta and A beta receptors send signal to antinociceptive neuron. Is this neuron inhibit presynaptic, has presynaptic inhibition of painful processing. There's stimulation of thick myelinated fiber, skin fiber, stimulates antinociceptive neuron in spinal cord, and this neuron inhibits painful propagation of painful sensation. And some
What mechanism?
your options, for example, stimulation. Your patient has great allergies, big allergy to anesthetic. What can you do? How to decrease pain? Because it's dangerous. You can use this method with electrical stimulation of skin with special parameters of electrical currents to stimulate A beta fibers, A beta, and A beta stimulates antinociceptive neuron with endorphin, and this neuron will inhibit pain processing. So it's a kind of more simple work, kinesiotape, kinesiotape, fiberization, kinesiotape glue to skin, kinesiotape stimulates these receptors, it decreases pain, local pain on skin or leg. My group, to the next class, I will give you homework, like control work, personal, it's It's impossible to cheat. Personal, you must describe your personal example of conditional reference. Your personal. From your life to find example of conditional reference in your life. And in addition, external, internal inhibition. And the next, I will, right, it's just a test, but no,
Okay.
I say about idea, да?
Mansion.
Is your personal example of conditional reference, not your personal. And your personal description of your emotions with need information theory, explain why do you have emotions in this situation. It's two
External and internal.
on the paper and I will check.
Bunlar